we'll go to the next three important topics. One is what is the role of albumin ICU, role of steroids in ICU, and the last would be ARNI. So my outline of the topic would be introduction, the types of albumin solutions which are commonly used in the ICU, and the important one is the role of albumin in different situations. Like what is the role of albumin in sepsis, ARDS, cirrhosis, renal replacement therapy, in perioperative period, and as a deresuscitative measure. So previously, two times the questions on albumin have been asked. One is in DRNB 2022, describe in brief about human albumin, what are its functions for 5 marks, and clinical utility as per evidences, 5 marks. The next was recently in 2024 May, they have asked about 20% albumin. So as we all know, albumin is a natural protein which is produced exclusively in the liver in amounts as high as 9 to 14 grams per day. So the half-life of albumin is around 18 to 19 days. So coming to the functions of albumin, so the main important function of albumin is that it maintains the colloidal osmotic pressure. Coming to the other things, so it helps in the transport of certain drugs. It affects the vascular integrity. It helps in binding and transport of certain molecules apart from the drugs. Also, it has some antioxidant and free radical scavenging functions. Also, it has anticoagulate and antithrombotic effects. And finally, it has anti-inflammatory action also. So coming to the different albumin solutions, so we have two forms. One is the iso-oncotic solution and one is the hyper-oncotic solution. So iso-oncotic solutions are available as albumin 4 to 5% and hyper is albumin 20 to 25%. So basically, what is the function of this iso-oncotic solution? It helps in intravascular volume expansion. So basically, it is used as an emergency treatment for some hypovolemic shocks, in cardiopulmonary bypass surgeries, and in acute liver failure. And this hyper-oncotic solution is basically used for the restoration of the colloidal osmotic pressure. So the main functions are in hypovolemic shock, in hypoproteinemias, ARDS, hemolytic diseases of newborns, acute nephrosis, acute liver failure, in renal dialysis, Burns therapy, and in cardiopulmonary bypass surgeries. So what is the role of, what are the side effects of hypoalbuminemia in critically ill patients? So what is hypoalbuminemia? It is nothing but less than 30 gram per liter of albumin in the serum. So most of the studies shows that this hypoalbuminemia leads to increased capillary permeability, leading to fluid redistributions from the intravascular to interstitial space. So this is associated with increased morbidity as well as mortality. Now coming to a meta-analysis which was showing that for every 10 gram per liter decrease in serum albumin concentration, the odds ratio of mortality, it increased by 137%. So there is a clear correlation between albumin serum concentration and morbidity rates. However, the question still remains that if albumin replacement improves outcomes or if hypoalbuminemia is just a marker for severity of illness. Now we will go to the individual uses of albumin in different situations. So the first important one is in sepsis. So what is the use of albumin in sepsis? So it is basically considered for volume resuscitation in septic patients because of its plasma volume expansion capability, and second, it potentially improves the hemodynamic stability. Now coming to the evidences which supports the use of albumin in sepsis, the first trial was the SAFE trial, which was published in the NEGM in 2004. So basically, what does the clinical question in the SAFE trial? So does fluid resuscitation with 4% albumin compared to 0.9% sodium chloride affect mortality? So it is a 28-day mortality which they are speaking about. So this is in all critically ill adult patients who have sepsis. Okay. So two groups, albumin versus saline. So there are two patient groups also. So one is all the patients who have been admitted to critical care units, and the other group was only the TBI patients. So what did the results tell? So they told that the 28-day mortality is similar for all patients when compared to the resuscitation, either with albumin or 0.9% sodium chloride. So there was no statistical significance. But when you come to this TBI patients, the 28-day mortality in the albumin group has been increased. Okay, so we should not use albumin for resuscitation in TBI patients. Now, second trial is the Albios trial. This was also published in the NEGM in 2014. So here, patients with severe sepsis in the past 24 hours. So this was the inclusion criteria for this. So what was the clinical question? Does the replacement of albumin in patients with severe sepsis, it improves mortality compared to no replacement? Okay, so they have checked 30-day mortality and as well as 90-day mortality. But there was no statistical difference. Okay, so there was no much difference in both the groups. So whether to give albumin still remains a question mark. In 2011, there was one more study, the IRAS albumin resuscitation study, which basically included patients with septic shock. Here, the authors were able to demonstrate improved survival in the group receiving albumin compared to the group receiving crystalloids. But due to insufficient patient recruitment, this study was stopped before a clear conclusion could be drawn, and it was only published as an abstract. So, a pooled analysis of these three trials, the SAFE, the Albios, and the IRAS trial, they have identified improved outcomes for patients resuscitated with albumin. Post which, there is one ongoing trial, the ARIS trial, which has not been published yet. So they are also comparing the role of albumin in sepsis. So results are still awaited. Now, after all this trial, the recent surviving sepsis guidelines, what does it tell? It tells that for adult patients with sepsis or septic shock, we suggest using albumin in patients who received large volume of crystalloids. This has a low level of recommendation and a moderate evidence. Now coming to the concerns regarding albumin in sepsis. One is we don't have a clear, there is a lack of clear benefits of the use of albumin because the trials still show inconclusive evidence for the benefit of the use in sepsis. Second, because of the costs in our Indian scenarios, the cost is also one of the issues. And safety issues, like there could be a risk of hypervolemia, pulmonary complications, there could be myocardial insufficiency and some hemorrhagic complications also. Now the second is albumin in ARDS. So we all know that restricted fluid management with reduced fluid intake or use of furosemide and albumin administration to achieve a negative fluid balance, it has been shown to be associated with improved oxygenation and reduced ventilation requirement in patients with ARDS. Okay, so what is the evidence for this? So there was a RCT which was published in 2005. So where they combined furosemide with or without albumin in hypoproteinemic patients with acute lung injury. And what were the results? So they told that addition of albumin to furosemide in hypoproteinemic patients with either acute lung injury or ARDS, it significantly improved oxygenation. Plus, there was a greater net negative fluid balance and it had a better maintenance of hemodynamic stability. Okay, so there is a role of albumin in ARDS to achieve a negative fluid balance. So next, there is one more which was published in 2014, which is a systematic review and meta-analysis where they have compared albumin versus crystalloid solution in patients with ARDS. Okay, and this systematic review have concluded that colloid therapy with albumin, it improved oxygenation, but did not affect mortality. Okay, so this affected both the previous one, but here only oxygenation has been improved, but there is no role in mortality. Now, next important one is albumin replacement in cirrhotic patients. So, in patients with end-stage liver disease, albumin is used both as a medication as well as a volume expander. Okay, so more supportive evidence for the use of albumin in these patients is available for large volume paracentesis, patients with HRS, and those patients with SBP. So we will go with each one. So this is just a gist of use of albumin in liver cirrhosis patients. So as we told, it is used in circulatory dysfunction. Okay, it is used in ascites, it is used in spontaneous bacterial peritonitis, and also in HRS. So each one has a specific role. So in HRS, albumin has an anti-inflammatory effect. It helps in small volume fluid resuscitation. It helps in improvement of the cardiac function, and it prevents renal dysfunction. Coming to the circulatory dysfunction, because of its oncotic pressure, it restores the circulatory volume, helps in fluid redistribution, helps in improved hemodynamic stability, and maintains or increases the MAP. In ascites, it helps in reduction of the edema, that is the abdominal edema or the ascites. It prevents the something known as paracentesis induced circulatory dysfunction. It helps in the expansion of the plasma volume and also leads to improved response to diuretic treatment. And lastly, in SBP, it has anti-inflammatory and antioxidant effects, helps in reduction in the renal impairment, and it improves the antibiotic delivery because most of the antibiotic basically are carried by this albumin. Now, the first one is large volume paracentesis. So, what is large volume paracentesis? Removing of more than 5 liters in a single situation. Okay, so when this happens, there will be some hemodynamic instability, which is known as paracentesis induced circulatory dysfunction. Okay, so if you come to the pathogenesis of this, so in patients with cirrhotics who has ascites, cirrhotic patients are already having a pre-existing arterial underfilling. In such patients, if you do a large volume paracentesis, so what happens? There will be some mechanical decompression of this splanchnic vascular bed, which leads to splanchnic vasodilatation and accentuated decrease in the systemic vascular resistance. So when this happens, there will be further decrease in the arterial filling, leading to the activation of the baroreceptors as well as the RAS system activation. So when this happens, there is rapid water and sodium retention, leading to a lot of phenomena like accumulation of ascites. Once you remove, there will be reaccumulation. There could be renal failure, there is a HRS. There could be hepatic encephalopathy. There could be some metabolic derangements like hyponatremia, uremia, and hyperammonemia. Okay. So to prevent this paracentesis induced circulatory dysfunction, so the British Society of Gastroenterology has recommended the use of albumin. So what is a dose of albumin for this? It is 6 to 8 gram for every liter of ascites removed. So this equates to around 100 ml bottle of 20% human albumin for 3 liters of ascites that is been drained. So roughly if you want to remove around 5 liters, so you require 2 bottles of 20% human albumin. Okay. So in patients who are hemodynamically unstable or those who are already suffering from a AKI, not a HRS, but there could be an AKI, 8 gram of albumin should be replaced for every liter of ascites, even if the amount of paracentesis is under 5 liters. Okay, in such cases, you have to transfuse it when the patient is hemodynamically unstable and if the patient has a pre-existing AKI. Okay. Now coming to the spontaneous bacterial peritonitis. So this is most common in patients with cirrhosis and ascites. Why does it happen? Because of the intestinal ischemia, the mucosal surface and the intestinal epithelia, they are damaged, leading to the bacterial translocation into ascites, causing SBP. So albumin has been shown to significantly increase the MAP through its potent expander qualities, leading to organ perfusion. Also, it reduces the RAS pathway activation, which has been explained previously. It improves the circulatory dysfunction, which is seen in SBP, and it reduces the renal impairment. But if your creatinine is less than 1 and your bilirubin is less than 4, then you need not give albumin infusion because these patients have a low risk of developing renal failure. So what is the dose of albumin for SBP? Okay, it is 1.5 gram per kg upon diagnosis of SBP and then 1 gram per kg on day 3. Okay. So you should know the different doses of albumin in different scenarios of CLD. Now next comes the hepatorenal syndrome. We all know this is a serious complication which might lead to high morbidity and mortality. So this is basically characterized by circulatory dysfunction which exceeds the compensatory mechanisms of the kidneys, prompting the vasoconstriction of the vas deferens resulting in decreased GFR. So as we know, the treatment of HRS is, one is vasopressor, that is nothing but the terlipressin which we use, and albumin combination. So what is the dose of albumin for HRS? So on day 1, 1 gram of albumin per kg body weight should be infused, which is followed by 20 to 40 gram daily for 2 to 16 days. So maximum you can give it for 2 weeks. Now, this is, I think, already we have discussed in our previous top classes about the pathophysiology of HRS. So, most important thing is in HRS pathophysiology. So, portal hypertension in cirrhosis may lead to increased splanchnic arterial vasodilatation, which causes decreased systemic vascular resistance, leading to decreased blood volume, which leads to activation of RAS, renal vasoconstriction, decrease in GFR, and hepatorenal syndrome. Now, where does our albumin act in this pathway? So, it acts in 2 places. So, one, it binds to the nitric oxide and the TNF alpha, and it reduces the splanchnic vasodilation. So, this is the first, mechanism where it acts. The second is here. Okay, so it increases the intravascular circulatory volume and it provides fluid resuscitation. So the effective blood volume will be increased by albumin. Okay, so when this is increased, the further pathway will be blocked. Now, is there a role of albumin in hepatic encephalopathy? As such, not proven, but it helps in treatment of hepatic encephalopathy. How? So, one is because of its potent plasma expander qualities, it can reduce the level of ammonia. How? By increasing the urinary excretion of ammonia. That is the first one. Second, it has some unique structure that is nothing but the free cysteine 34 residue. Okay, what does this thing do? It can ameliorate the inflammation by binding to TNF and interleukin 6, thereby preventing the breach of the blood-brain barrier. Third, it has antioxidant effects. So usually, the ions of copper and iron, they form free radical, which contribute to the development of edema, that is cerebral edema in these patients, hepatic encephalopathy patients. So what does albumin do? The albumin binds these free radicals, the copper and the iron, and exhibit a protective effect. The last one is it has a marked reduction in oxidative stress markers. So all these also help in the prevention of hepatic encephalopathy or in the treatment. So Sharma et al., there is a study done by Sharma et al. Who administered albumin with lactulose, and he observed that there is a decrement levels in the ammonia and there is reduction in mortality and reversal of HE in cirrhotic patients. So this is a beautiful slide which tells where all you can give albumin in cirrhotic patients and what is the dose of albumin. Okay, so if you write it in exam with this one slide, most of your albumin in CLD patients treatment will be completed. Okay, so for large volume paracentesis, for ascites, spontaneous bacterial peritonitis, hepatorenal syndrome, what is the dose? Okay. So next, there are some trials which are very important in this. I mean, a lot of trials are there where you can use albumin in cirrhotic patients. I'm not going in any details. Just if you know some names, you can write it in the exam. So you can write about ANSWER trial, ATTAL trial, and MATCH trial. So you can go through it in detail later. I'm not going through it. Now, the role of albumin in renal replacement therapy. So albumin administration during hemodialysis, they have seen that it improved the hemodynamic stability, it improved the fluid withdrawal, and also it increased overall safety. So there are two trials which actually support albumin in RRT. The one is the Mesido et al. They conducted a randomized crossover study to evaluate the effect of albumin in renal replacement therapy. So what they have done is they have assigned one group with albumin and the other group with a sodium chloride 0.9%. Both received 100 ml each. So they found that the albumin group experienced fewer episodes of hypotension compared to the sodium chloride group. The next is the renal study. Renal study is very popular. Basically, it gave the doses of CRRT. Basically, it gave the levels of intensity of CRRT doses. So, a subgroup of these patients who underwent a post hoc analysis to evaluate the effect of albumin, they have found that albumin treatment was associated with more effective fluid removal. So these two trials, they support the role of albumin in renal replacement therapy. Studies with larger sample size confirming these data are still lacking. Now, what is the role of perioperative albumin replacement? So one is, there was a prospective study conducted by Norberg. So they have conducted in both thoracic as well as abdominal surgeries. So they have seen in esophageal and pancreatic surgery. So whether during the perioperative period, is there a decrease in albumin levels? So they have measured it pre-operatively and 72 hours post-operatively, and they found that around these 3 to 4 days, because of increased third space losses and all, there is a decrease of albumin concentration in these patients. But there are very less trials which showed whether supplementing the albumin preoperatively will improve any mortality or improve, in the wound healing. No, there are no much trials. There is still a lack of evidence for this. Okay. Now, second is they evaluated the effect of albumin in cardiac surgery patients. So what they have done is patients with preoperative serum albumin of less than 4 gram per liter, they received albumin to maintain the serum concentration of more than 4 gram per liter. And they saw that those who were given albumin and they maintained the level more than 4 gram throughout the cardiac surgery, they saw that there was less risk of developing AKI in these patients. The third group was patients who are receiving the VA ECMO. Okay, so ECMO itself can trigger inflammation with capillary leak and intravascular volume depletion. So in these patients, they have given either albumin or balanced crystalloid solutions, and the results show that there is significant better survival in the albumin group. Okay, so this is in the perioperative management of the patients. Now, what is the role in de-resuscitation? Okay, so something known as PAL treatment. So this was published in 2012. So placebo with PAL treatment they have done. So what is this PAL treatment? P is for high levels of high levels of PEEP. Okay, A is for hypertonic albumin and L is for Lasix. So combining these three in patients with acute lung injury, they saw whether there is any benefit. Okay, so this PAL treatment is associated with a negative fluid balance. There is a reduction of extravascular lung water, and there is also a reduction of intra-abdominal pressure with some improved clinical outcomes without compromising the organ function. So this is about the PAL treatment. So this is a Kaplan-Meier plot which shows that the cumulative survival is better with the PAL treatment, and the proportion of mechanically ventilated patients, those requiring ventilator, were actually less in PAL treatment. Because all these three combination together has made a restrictive fluid management in acute lung injury patients. So this is a beautiful slide which says where is albumin recommended, where it has a possible role but limited evidence, and where it is a harm. Okay. So it is recommended in sepsis resuscitation after large volumes of crystalloids, Recommended in CLD patients with spontaneous bacterial peritonitis, hepatorenal syndrome, and large volume paracentesis. And the last one is ultrafiltration in patients with hypoalbuminemia. Sorry. It has a possible role, but evidence is limited or uncertain in cases of diuretic resistance, sepsis, and cardiac surgery. And it is harmful in case of extraperitoneal infections in patients with liver cirrhosis and acute brain injury, especially the TBI. So these are my references.
That was a nice talk, man. I think so. If they look into these aspects, they can write a flow chart. Most of the diagrams were quite descriptive. Guys, the albumin has been asked multiple times. I think so. If you can go through this talk again, it will be really helpful. Next talk is also something that we anticipate. Steroids have been used in multiple settings, be it ARDS or otherwise, like community acquired pneumonia. So please look into the next slides as well. Over to you, ma'am.
Yeah, so steroids in ICU. I mean, steroids are used in ICU, I mean, very rampantly. I never knew that you use it for so many things, but when I was preparing this slide, I was surprised that actually we use for many of the scenarios in the ICU. So we'll just go through it. So I'll be discussing about the introduction, the physiology of the steroids, and its role. Basically, it is used in many situations. So we'll just go through the topic directly. So steroids are basically classified into glucocorticoids and mineralocorticoids. So we'll be dealing here with glucocorticoids. So glucocorticoids are potent anti-inflammatory medications which are frequently used in the treatment of critically ill patients. So the most common systemic glucocorticoids which we use are prednisolone, methylprednisolone, and hydrocortisone. And they all have the action which are similar to that occurring in the body. So now what is the role of this cortisol or the glucocorticoids in our body? So it acts in it acts on each and every system. So basically in the eye, it has an anti-inflammatory, anti-angiogenesis. In nervous system, it maintains the homeostasis and it responds to the stresses. In cardiovascular system, it has an anti-inflammatory, cardiomyocyte survival. It helps in increasing the blood pressure and vascular tone, and also it has an anti-angiogenesis property. In the immune system, it suppresses the pro-inflammatory cytokines. There is a regulation of the immune cell maturation, migration, as well as apoptosis. So in musculoskeletal system, it has anti-inflammatory properties. It has muscle catabolism and anabolism properties. There is insulin resistance and osteoblast apoptosis and osteoclastogenesis. In reproductive system, it is very important for gonadal function and fetal organ maturation. It also helps in glucose regulation and lipid homeostasis. And in respiratory system, it has suppression of cytokines, chemokines, and cell adhesion molecules. Because of all these mechanisms, a trial of glucocorticoids is often used in critical illness when dysregulation of the inflammatory response is proposed to be the underlying pathology. Because it helps to limit the organ damage, it promotes the recovery of organ function, and helps in improving the mortality. However, there are a lot of serious side effects which happens with steroids. So the important ones in ICU being any new infections, hyperglycemia, and critical illness myopathy. So in order to maximize the benefit and to limit the harms, we must be aware of the evidences which justify the use of glucocorticoids. So this is just some physiology. So cortisol is basically a product of cholesterol metabolism in the zona fasciculata. It is highest in the morning and it is lowest during the night while sleeping. Under non-stressed conditions, the normal value is around 20 mg. Whereas in any stressors like infection, trauma, or diseases, it might increase up to 150 to 200 mg. Now coming to the physiology. So we know that endogenous cortisol production by the adrenal gland is actually controlled by the HPA axis, right? And this occurs basically in a diurnal and circadian patterns every 24 hours. So due to a lot of CNS stimuli, which could be temperature change, energy expenditure, any stresses, inflammation, tissue repair, all these CNS stimuli will lead the hypothalamus to release the corticotropin releasing hormone. So this hormone acts on the anterior pituitary and releases the ACTH, which acts on the adrenal cortex, and via the adrenal cortex it goes to the end organs. Okay. Now coming to the role of steroids in septic shock. So sepsis and septic shock, they develop when the inflammation spreads beyond the initial site of an infection, leading to systemic pro-inflammatory cascade, which overwhelms the body's anti-inflammatory processes, leading to diffuse cellular injury and multi-organ damage. So this inflammatory mechanism, it provides a rationale for the use of steroids in the treatment of septic shock. So there is a lot of theoretical benefits of steroids in septic shock. So basically, it increases the sensitivity of alpha and beta adrenergic receptors. It decreases the release of adhesion molecules. It increases the transcription of anti-inflammatory cytokines, decreases the transcription of pro-inflammatory cytokines. It inhibits arachidonic acid. It inhibits the platelet activating factor, prevents neutrophil aggregation. It inhibits the inducible form of nitric oxide, and it prevents complement activation. So these are the theoretical benefits of steroids in sepsis. Okay, so a lot of evidences, a lot of research has been done in this steroids in septic shock. So it started from around 1976 and now it's still ongoing. So we'll just discuss about the important trials. Okay, this is very important for you for the exam. So the first trial was the ANAN trial. So where it is a double-blinded study where they gave 50 mg of hydrocortisone Q6 hourly with fludrocortisone 50 mg, and they've compared it with placebo for 7 days. And what did they find? They've seen that 28-day mortality in septic patients with relative adrenal insufficiency. Okay, they've basically seen the primary outcome was deaths. So in hydrocortisone plus fludrocortisone, the 28-day mortality was around 60, that is 53%, whereas in the placebo, it was around 63%. Coming to the secondary outcomes, they saw was mortality at the end of ICU stay, mortality at 1 year follow-up, vasopressor therapy discontinuation at 28 days, and median time to vasopressor therapy discontinuation. So coming to this, there was no significant effect of steroids on mortality in responders, but among non-responders. Who are non-responders? Patients with septic shock and adrenal insufficiency. Low-dose steroids have reduced the 28-day mortality and also the vasopressor dependence time. Okay, so this showed some positive effect, steroids in septic shock. Now next came the Corticus trial and the Hypres trial. Okay, so Corticus trial was in 2008 and this Hypres trial was in 2016. So Corticus trial had also compared hydrocortisone with the placebo, and they have concluded that there was no significant difference in 28-day mortality in patients who did not have a response to corticotropin. Okay, so there was no much response. Now coming to the Hypres trial. So Hypres trial also they have given hydrocortisone with the placebo. So they showed that a continuous infusion followed by the tapering dose of hydrocortisone, it did not prevent severe sepsis to septic shock progression within 14 days of treatment initiation when compared to the placebo. Now next came the adrenal trial and the approaches trial. So adrenal trial both were in 2018. So what did the adrenal trial tell? Same, this also hydrocortisone with placebo. They told that continuous infusions did not result in lower 90-day mortality. Okay, but the steroid use had led to more rapid resolution of the shock, shorter inpatient ICU time, and lower incidence of blood transfusion. So mortality wise, there was no much benefit, but requirement of vasopressors was less in adrenal trial. Now, what did the approaches trial tell? So in approaches trial, they used hydrocort plus fludrocort. So in ANAN and approaches, they used both hydrocort plus fludrocort. So what they have showed is, the combination showed both a mortality and resolution to shock benefit. So here, this is the one trial which has showed that there is some mortality benefit. This was in the recent 2018. So, but the steroid regime was also shown to be safe because there was less incidence of hyperglycemia and also less incidence of new onset infections. So, now when you give the steroids as a septic dose, would you require a tapering of the steroid or can we stop it abruptly? Okay, so basically if you come HPA axis suppression, so standard dose cortisone, which is nothing but 20 mg per day, which we usually give 50 q 6 hourly, it mimics the physiological cortisol production during stress, which minimizes the risk of HPA axis suppression. So tapering is not required for less than or equal to 7 days of therapy. Okay. Second, shock resolution. So abrupt cessation of corticosteroids after 5 to 7 days showed no recurrence of shock or rebound inflammation in many of the RCTs, especially in the adrenal trial and the approaches trial. Now, as I told, duration, if it is less than 7 days, you need not to taper it. And adverse effects, if you give it within 200 mg per day, then adverse effects are also less. Okay, so whatever dose which we are giving for the sepsis, there is no much adverse effects and you need not to taper the dose. You can stop it abruptly. So driven by all these trials, results and all, the 2024 sepsis guidelines, they included a conditional recommendation in favor of low dose corticosteroids in patients with ongoing shock following fluid resuscitation. Now coming to the respiratory system. So first we will see role of steroids in ARDS. As we all know, ARDS is an intense inflammatory process which occurs at the level of alveoli, alveolar blood membrane, and pulmonary interstitium. So when this happens, this alveolar space is filled with fluids, cellular debris, and inflammatory cytokines, all of which leads to severe gas exchange abnormalities with subsequent hypoxia, and in severe cases, it may even lead to hypercapnia. And we have to remember that the inflammation in ARDS is dynamic. It changes very rapidly. So normally in the initial phases of the disease, it is basically characterized by the development of edema and hyaline membrane formation. Whereas in the second week, it is basically characterized by the presence of interstitial inflammation and development of interstitial fibrosis. So these are the different trials which have been done with the steroids in ARDS. Important one which you have to remember is the MEDURI trial. Okay, so basically in 1987, the Bernard showed that when you give methylprednisolone every 6 hours, there is no difference in mortality. Okay, but MEDURI 1998 showed that methylprednisolone in a dose of 2 mg per kg followed by tapering showed improved lung injury severity score, plus there is improved ICU and in-hospital mortality. From then, a lot of work has been done on this steroids in ARDS. Then came Steinberg, who told that no, there is no difference in mortality when you give steroids. So again, after this, MEDURI in the next year, because he has done this and he showed that there is an improved survival rate, he has again done it with low dose, methylprednisolone 1 mg per kg. So here he has done it with 2 mg per kg. Here it is 1 mg per kg for around 28 days. And he showed that there is an improvement in the length of ICU stay is decreased, the duration of mechanical ventilation is decreased, and ICU length of stay is also decreased. Okay, so in 2021, Lin has done a meta-analysis of 9 studies and he showed that steroids have improved the mortality, the ventilator-free days at 28 days, and there is an increase in PF ratios. So after all this, the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, they proposed or they suggested the use of steroids in patients with moderate to severe ARDS within 14 days of disease onset. If you give it after 2 weeks, there is no role of steroids. Okay. However, this recommendation was conditional and it was based on moderate quality of evidence. the same guidelines also recommend that you have to do surveillance to see if there is any hospital-acquired infection during therapy, because steroids cause new onset of infection. Now, role in severe pneumonia. Okay, so basically, the community-acquired pneumonia is characterized by inflammation due to increased pulmonary as well as circulatory inflammatory cytokines. That is where you have to use steroids. So now this started in 2005. There are a lot of things that initially they told that it has improved mortality. Then in 2011 to 22, there are a lot of studies. Even Meduri has done a study here in CAP, and he told that there is no difference in mortality. Now, recently in 2023, Dickwin has done a trial that is nothing but the Cape Cod trial. I think you people have heard about that. So here they have given hydrocortisone 200 mg daily for 4 to 7 days and then tapered it. And this trial showed that there was an improved 28-day mortality. Okay. So the evidence supporting the use of steroids in severe community-acquired pneumonia, it appears relatively strong when this hydrocortisone infusion is administered early in the course of the disease. Whereas there are trials which has also seen the benefits with methylprednisolone, but compared to hydrocortisone, they saw that the benefits are less compared with methylprednisolone. Data on nosocomial pneumonia are very limited, and the safety of steroids in influenza pneumonia, it still remains in question. So if there is an influenza pneumonia, should we give steroids or not? Initially, they told it is contraindicated, but now there is still a lot of ongoing research being done on this. Now, what is a role in COVID-19? I think everyone know about the COVID-19. What is the recovery trial? Basically, it became very famous. So we were giving steroids to those patients with who are on oxygen requirement. So glucocorticoids were among the first therapies which were studied in the management of patients with severe SARS infection. So inflammatory markers and cytokines including CRP, ferritin, interleukins are elevated in COVID-19, and it correlates with the intensity of the disease also. So there were 3 trials which were doing side by side the work on this. So in 2020, we have Dickwin and Tomazini were doing the trials, but then in 2021, recovery trial has been started. But before these both could publish their results, the recovery trial told that dexamethasone 6 mg daily for up to 10 days has improved the mortality. Okay, so both these trials should be stopped early because the recovery results were already released. Now, this is about the 2024 focused update for the guidelines on the use of steroids in sepsis, ARDS, and community-acquired pneumonia. So what does the evidence tell? In sepsis and septic shock, they suggest administering steroids to adult patients with septic shock, which is a conditional recommendation and a low certainty evidence. But in those patients who have, they have recommended against the administration of high dose short duration, that is more than 400 mg per day of hydrocortisone. So they recommended against the use of this high dose, which is a strong recommendation and moderate certainty evidence. Coming to the ARDS, they suggest administering the steroids to patients with ARDS, which is a conditional recommendation, whereas in community acquired pneumonia, there is a strong recommendation for administering steroids to those patients who are hospitalized with severe bacterial community acquired pneumonia. Okay, so just go through the doses. Okay, if you have time. Now we'll come to what is the role of steroid in hypercapnic respiratory failure, that is the COPD. So we know that in COPD patients, a lot of steroids has been used, right? So systemic steroids are used extensively in the treatment of hypercapnic respiratory failure due to COPD because airway inflammation underlies the acute exacerbation and it results in air trapping, which impairs the ventilation. But despite this widespread use of steroids, there is very little evidence to support this use in COPD patients. So we have just only 2 trials. Okay, the ALIA trial and the OBRAM trial, and both of the trials showed that there is no difference in mortality, whereas it significantly reduced the duration of mechanical ventilation and failure of NIV. And in OBRAM, it showed increased hyperglycemic events. So as such, there is no mortality benefit in COPD patients in respect to the steroids. So in patients with hypercapnic respiratory failure due to asthma, okay, there is a clearer role of steroids. Okay, you should give steroids in these patients. So now coming to the guidelines. So for COPD exacerbations, what does the GOLD 2024 guidelines tell? You can give steroids in the dose of 40 mg per day for a maximum of around 5 days. Whereas for asthma exacerbations, the GINA guidelines 2024 tell that either prednisolone or any equivalent, the dose is around 1 mg per kg per day, maximum of around 50 mg per day, and you can give it for 5 to 7 days. Now, what is the role in airway edema? Okay, so airway edema, especially the laryngeal edema, is actually because of the complication of the endotracheal intubation. So this laryngeal edema may lead to post-extubation stridor and increased chances of reintubation. So hence we give steroids, especially the most common used steroid is dexamethasone, around 0.5 to 2 mg per kg divided over 4 to 6 hours, started 24 hours before extubation, and it is continued for 24 hours after extubation. So you give around for 2 days. So there was a systemic review and a meta-analysis which was showing the comparative efficacies of various corticosteroids for preventing the post-extubation stridor. So they have compared methylprednisolone, dexamethasone, and hydrocortisone, and they told that for stridor, to prevent stridor, the best one would be methylprednisolone, and to prevent reintubation, dexamethasone would be the best steroid. Okay, so what does the clinical recommendation now suggest? So corticosteroids, they are most effective when administered pre-extubation, that is 24 to 48 hours. Post-extubation use is not routine, but may be considered for those patients with high-risk features, like if the patient tested for a positive cuff leak test, or if there is severe airway edema, then in such cases, you can even continue it post-extubation also. So there are a lot of regimes, pre-extubation, methylprednisolone, or dexamethasone can be given, whereas post-extubation, dexamethasone 5 mg every 12 hourly for 48 hours in selected high-risk cases you can give. Now, what is the role in ILD or pulmonary fibrosis patients? So, there are a lot of guidelines here. So, for idiopathic pulmonary fibrosis, corticosteroids are not recommended routinely. Only it is used in acute exacerbations, that too on a case-by-case basis. Now, coming to the acute exacerbations of the IPF, as I told, you can give in acute exacerbations. The dose is 0.5 to 1 mg per kg per day of prednisolone. You can give it for 2 to 4 weeks and then taper. Now, coming to the connective tissue associated, like SLE, associated ILD, you can give prednisolone in the dose of 0.5 to 1 mg per kg per day and then taper it. It is often combined with other immunosuppressive therapies. And coming to the last one, the hypersensitive pneumonitis, you can give prednisolone for around, you have to give it for a longer period for hypersensitivity pneumonitis. It is 4 to 6 weeks. So what is the role in PCP pneumonia? So basically in PCP pneumonia, glucocorticoids or corticosteroids are given as an adjunctive therapy with the standard treatment like cotrimoxazole, right? So usually the steroid dose is 40 mg twice daily for 5 days. Then the same 40 mg once a day for 5 days and then 20 mg once daily for 11 days. So totally in PCP pneumonia, you are going to give the steroids for 21 days. So what is the effect of the steroids in PCP pneumonia? It reduces mortality, particularly in moderate to severe PCP cases. It showed improved survival benefits. It reduced the complications such as pneumothorax and also respiratory failure. Okay, and a meta-analysis showed that it reduced the mortality by 0.55 times compared to the control groups where only standard therapy has been given. So now the guidelines recommend that steroids should be initiated within 72 hours of starting any PCP therapy, that is a standard therapy. And if the patient has a resting room air oxygen saturation of less than 92%, or if the PaO2 is less than 70 mmHg on room air, or if there is a increased AA gradient of more than 35 mmHg. In all these situations, you need to start the steroids in PCP pneumonia 72 hours, within 72 hours of start of the standard therapy. Okay, so this is the guideline. Now coming to something known as metabolic resuscitation. So what is metabolic resuscitation? I think this is an expected question in your exams. So what is metabolic resuscitation? It is nothing but mitochondrial target therapy, especially for sepsis and septic shock, is known as metabolic resuscitation. Okay, this resuscitation could be either pharmacological or nutritional. Okay, why this concept came? Because mitochondrial dysfunction, it occurs early in sepsis and it has a central role in the development of multi-organ dysfunction syndrome. Okay, so what is the most common metabolic resuscitation that has been, I mean, previous few years this was there, the HAT therapy, the hydrocortisone, vitamin C and thiamine. So this therapy was proposed as an adjunctive therapy for sepsis, which was aimed at addressing the mitochondrial dysfunction and oxidative stress, which was the central to sepsis pathophysiology. So this combination was synergistically, it was modulating the mitochondrial metabolism, it was reducing the oxidative damage, and it was improving the outcomes in septic patients. So this is the synergistic action of the HAT therapy. So if you see, thiamine is basically a coenzyme for many cycles or many metabolic pathways. So important one being the glycolysis and the Krebs cycle. So thiamine is required for these. Second, vitamin C in septic shock, basically it reduces the oxidative stress, increases the microcirculation, decreases the neutrophil extracellular traps, increases the catecholamine synthesis. And hydrocortisone, it actually facilitate the transport or transshipment of this vitamin C. And in fact, vitamin C also promotes the synthesis of this increased synthesis of steroids in the body. So hence they have done this HAT therapy as a part of metabolic resuscitation. So I think you know a lot of trials on this HAT therapy has been done. So it started in 2017 and that is Marik et al. Started this. So which showed that there was improved survival and vasopressor independence in septic shock. Later, uh, Anane et al. In 2018 showed that it also reduced mortality and improved hemodynamic stability. But later on, from 2020, a lot of trial, vitamins trial, oranges, acts, Victor, everything has been showed that there is no significant difference in the mortality or the vasopressor free days. So I think during the COVID time, everyone was giving this HAT therapy, but post 2020, I mean, it's been slowly reduced, this HAT therapy. So now, what is the role of steroids in central nervous system? So first one would be your meningitis and encephalitis. So it has a role in streptococcal pneumonia meningitis because it's reduced mortality and also it prevents neurological complications. Okay, so the dose is dexamethasone 10 mg IV every 6 hourly for 4 days. So this steroids should be administered before or with the first dose of antibiotic in case of streptococcal bacterial meningitis. Okay, next in H influenza, which is most commonly found in children, steroids are indicated here. Second, in Neisseria meningitis, there is a limited evidence. Coming to the Listeria monocytogenes and cryptococcal meningitis, basically they are contraindicated because it has very adverse outcomes. It has increased the mortality. Coming to the tuberculosis meningitis, steroids are recommended and the dose is 0.4 mg per kg per day, tapered over 6 to 8 weeks. Now coming to the herpes simplex virus, it has limited evidence, may be used in case of HSV-induced cerebral edema. In autoimmune encephalitis, the main treatment only is about steroids. So the commonly used steroid is methylprednisolone, 1 gram IV daily for 3 to 5 days, which is followed by oral prednisolone tapered over weeks. In neurocystisarcosis, it is recommended with antiparasitics. And in brain abscess, it has limited limited to cases with cerebral edema alone. Now, what is the role in spinal cord injury? So, initially, a lot of evidence showed that high dose steroids in spinal cord injury will reduce the inflammation and then the chances of decrease in weakness of the limbs. So, basically, why do we need this? Because it has an anti-inflammatory properties to reduce the spinal cord edema. So, what are the neuroprotective effects of steroids? It improves vascular perfusion, it prevents calcium influx, modulation of inflammatory cells, prevention of neurofilament loss, inhibition of lipid peroxidation, and inflammatory cytokines. So, what is the key agent here? It is methylprednisolone. So, we have a lot of trials. So, basically, the NASIX 1, 2, and 3 trials are the important trials for the steroids in spinal cord. So, the first trial was done in 1984, which compared low dose steroid versus high dose steroid. Okay, within 48 hours of the spinal cord injury. And they showed there was no difference in neurological improvement, but higher complications with high dose methylprednisolone. Okay, here there was no placebo, only they compared high and low dose. Now, in NASIX 2, they compared the methylprednisolone, naloxone, and placebo within 12 hours of spinal cord injuries. And they showed that significant motor and sensory recovery with methylprednisolone within 8 hours of spinal cord had showed some mortality, benefit, but there is some increased complications like infections. Whereas the NASIX 3, it compared 24 hours versus 48 hours methylprednisolone within 3 hours of spinal cord. So if you see, initially it was 48 hours, then it came to 12 hours of spinal cord injuries. Now this came with early initiation of steroids within 3 hours only. Okay, so but there was no difference in outcomes for treatment initiated within 3 hours. Okay, so what does the guidelines tell? So the guidelines tell that initially in 2017, the AO spine guidelines suggested a 24-hour high-dose methylprednisolone infusion within 8 hours of spinal cord injury as a treatment option. But now, after lots of trials, the evidence show that there is no neurological improvement with this high dose of methylprednisolone. Now, coming to the role in cerebral edema, I think Sanantha sir have already discussed about the management of cerebral edema. So, what is the recommendation for the ICH? It is not recommended for intracranial hemorrhage due to increased mortality and infectious complications. The reference is the CRASH trial. Now, coming to the vasogenic edema. Yes, it is the corticosteroids are used to decrease the vasogenic edema, especially in brain tumors. Okay, so what is the dose here? The preferred agent would be dexamethasone and the dose would be 4 to 10 mg IV or orally every 6 hours. Okay. Now coming to the other uses of steroids. One is role in anaphylaxis. So basically, how does it help in anaphylaxis? So these corticosteroids, they reduce the number of mast cells and basophils. They downregulate the transcription of pro-inflammatory molecules and they upregulate the anti-inflammatory mediators and they rapidly decrease the mast cell release. This is how steroids have a role in anaphylaxis. So what does the guideline tell? So we all know that epinephrine is the first line therapy, whereas glucocorticoids are suggested as second or a third line therapies by almost most of the guidelines, except the American guidelines, which do not endorse their use at all. Okay. Now coming to the role in thyroid storm. So how does steroid help in thyroid storm? They reduce the conversion of T4 to T3. Thyrotoxicosis is associated with subtle impairment of adrenocortical reserve by itself. So there is a role of steroids for this. So what is the dose? So we use hydrocortisone 100 mg every 6 to 8 hourly, or you can also use DEXA, but it's not regularly used. The most common was hydrocortisone. So analysis of a nationwide administrative database, it indicates that administration of the steroids does not improve the survival of patients with thyroid storm. It is only basically it reduces the conversion of T4 to T3. Now, what is the role in myxedema coma? So, possibility of secondary hypothyroidism and associated hypopituitarism is most commonly seen in myxedema coma. So, hydrocortisone should be given until the adrenal insufficiency is excluded. Okay, so it should be given at a dose of same 100 mg every 6 to 8 hourly. Not treating the adrenal insufficiency with hydrocortisone may precipitate the adrenal crisis. That's why you need to treat these patients with hydrocortisone. So before therapy, a random cortisol level should be drawn, and if not depressed, the hydrocortisone can be stopped without tapering. Now, last one, in brain dead patients. Yes, we use steroids as a part of triple therapy. Okay, brain death can cause pituitary deficiency, promoting hemodynamic instability. Steroids may reduce the inflammation, thereby improving the graft organ functionality. So, most commonly used is the methylprednisolone 15 mg per kg immediately after the diagnosis of brain death, and then every 24 hours afterwards. Alternatively, you can also give methylprednisolone as 250 mg bolus followed by 100 mg per hour infusion until organ retrieval. So this completes the second topic, and I'm sorry, there is one more topic left.
It's really great that 42 of you have stayed back till the end. I think so you're going to benefit from this. So that was a really good presentation, ma'am.
Thank you. So my last talk is on ARNI. Okay, some few slides, so we'll just go. So I'll be discussing about the introduction, the neurohormonal activation in heart failure, because that is how the mechanism of action of ARNI comes, and then we will discuss in detail. So coming to just some introduction. So heart failure, it is a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or ejection of blood. So this is a beautiful classification of heart failure. So you have the AHA or ACC classification, the NYHA classification, and the intermasses profile. So AHA, ACC stages, you should know A, B, C, D. Okay, I'm not going to go in detail about that, but just remember about the C and D. So basically A is at risk patients for heart failure, but there is no structural heart disease and there are no signs and symptoms for heart failure. B is there is a structural heart disease, but there are no signs and symptoms of heart failure. C is there is a structural heart disease with prior or current heart failure symptoms. And D is refractory heart failure, which requires specialized interventions. NYHA class, I think you people know it. Now coming to the new classification of heart failure according to the ejection fraction. Okay, so we all know that, yeah, there is a reduced ejection fraction, there is a preserved ejection fraction. So there are others also. So reduced ejection fraction, we know that if the ejection fraction is less than or equal to 40%, and preserved ejection fraction is more or equal to 50. So in between there is 40 to 49, something known as heart failure with mildly reduced ejection fraction. And there is something known as heart failure with improved ejection fraction. So what does that mean? Baseline, the ejection fraction was 40%. Later, because of some treatment, the ejection fraction has improved to more than 40%. So that is known as heart failure with improved ejection fraction. Now coming to the neurohormonal activation in heart failure. So what happens in heart failure? Three important systems will act. The first one is the RAS system. Second one is the sympathetic nervous system. The third one is the natriuretic peptide system. Okay. So what happens in the failing heart? In the failing heart, the RAS system gets activated. So the renin is released, which converts the angiotensinogen to angiotensin 1. And this angiotensin 1, okay, will be converted to angiotensin 2. And this angiotensin 2 has some receptors which acts on it, and then it leads to worsening of the heart failure. Okay, so the RAS system basically consists of the angiotensin receptors, the aldosterone, okay, and the basically these both, angiotensin and the aldosterone. So where does this ACE inhibitors act? Basically, they stop conversion of angiotensin 1 to angiotensin 2. That is where the ACE inhibitors act. Where does this ARB acts? They act on the angiotensin receptor 1. They block these receptors. Okay. The third one is the second one is the sympathetic nervous system. So where you give the beta blockers. Okay. And the third one is the natriuretic peptide system. The important The substance which is important here is the neprilysin. Okay, so it basically changes into inactive peptides leading to natriuresis, vasodilation, and PNS activation leading to heart failure. Okay. Now, if you see the action of ARNI, so ARNI contains two important things, the sacubitril and the valsartan. So valsartan is nothing but a ARB. So basically it acts on this angiotensin receptor 1. And sacubitril is nothing but the inhibitor of this neprilysin. Okay. So basically this ARNI acts on two important pathophysiological systems. One is the RAS and one is the natriuretic peptide system. Okay, so you need to understand this diagram. So coming to the natriuretic peptide family properties. So basically this family includes three different molecules. One is the ANP, BNP and the CNP. All this play a key role in the cardiorenal homeostasis. So they are mostly synthesized within the heart in response to volume overload and myocyte stress and in response to some neuroendocrine regulation. Okay. Mostly these natriuretic peptide effects are mediated by vanillyl cyclase receptors. Okay. So in that we have two, NPR-A and NPR-B. I think you need not to know in detail about this. So what is the biological signature of this NPs? It is to reduce the body fluid and it maintains the BP and the cardiovascular homeostasis. And by this, there is a physiological antagonists of both the sympathetic nervous system as well as the RAS system, which are nothing but the fundamental factors in heart failure. So coming to the ARNI, so it is approved under the FDA's priority review process for use in heart failure in 2015. So basically, as we know, ARNI combines two things. One is the natriuretic peptide inhibition due to sacubitril, and second is the angiotensin 2 receptor 1 inhibition by the valsartan, which offers the benefits of the two-step approach whilst it avoiding the side effects of an increase in bradykinin due to dual inhibition of its metabolism. So this basically contains, as I told, valsartan and a sacubitril. Sacubitril is a prodrug. Okay, it is converted into an active form which is known as sacubitrilat. Okay, by deethylation via esterases. So both are in 1:1 ratio. The concentration is in 1:1 ratio. Now this is important. Something known as co-crystal formation of sacubitril and valsartan. So if you see individual agents, how they look, okay, sacubitril and valsartan. So when you combine it, okay, that is known as co-crystal formulation. Okay, so the single chemical entity of sacubitril and valsartan in 1:1 ratio. So what is the advantage of this co-crystal formation? Okay, so it has a higher dissolution rate. There is a simultaneous release with the desired simultaneous inhibition of both the neprilysin as well as the angiotensin receptor. Also, it has a higher bioavailability. So this is the advantages of the co-crystal formation. Now coming to the pharmacokinetics. So absorption, the time to peak is around 30 minutes, whereas the time to peak of the metabolite, the active form of the sacubitril, is around 2 hours. Coming to the distribution, the protein binding is around 94 to 97%, whereas the volume of distribution is around 103 liters. Metabolism I've already discussed by esterases. And what is the T half? Elimination T half is around 12 hours, and basically it is eliminated in urine and feces. Valsartan in urine and sacubitril in feces. So this is important. Who should be treated with an ARNI? So this is considered as a first line therapy in patients with class C. Okay, the AHA class C, heart failure with reduced ejection fraction. So these are the patient who has to be treated with ARNI. Okay, so it can be started either in hospital once the patient has been stabilized, or you can start it as an out of hospital also. So the second question is, should ARNI be used as a monotherapy or in association with other agents? And is there any specific order in which these drugs has to be started? So in patients with class C heart failure, this ARNI should be used in association with a beta blocker and a mineraloc. So in order in which these agents should be used is individualized. So as a rule of thumb, when to start Vimada in patients, in hospital patients is the systolic BP over the preceding 6 hours should be more than or equal to 100 mmHg. Second, the diuretic doses should be stable enough. There should be no intravenous vasodilators in the preceding 6 hours. And they should not have, patient should not be on intravenous inotropes or pressor agents within the preceding 24 hours. So this is the time when you start sacubitril and valsartan in hospital patients. Now, in patients who present with a new onset heart failure in out of hospital settings, that in an OPD, the order in which these drugs has to be initiated is flexible. Okay, so which are the factors which decide upon which has to be initiated first? It includes what is the blood pressure of the patient, what is the patient having a renal dysfunction, and if there is a renal dysfunction, how severe is the renal dysfunction, what is the potassium levels, and what is the magnitude of congestive signs and symptoms which the patient has. So now important is what is the starting dose of sacubitril and valsartan. So it depends on whether the patient has come to your OPD or whether the patient is in the hospital. So this is just for your information how to start in an OPD basis patient. So basically the starting dose will depend on the dose of RAS blockers which the patient has already been taking. Suppose if the patient is on ACE inhibitors, okay, then you have to see the dose of ACE inhibitors. Suppose if the patient is taking enalapril or any other equivalent, so if the dose is less than or equal to 10 mg, then you have to start with 50 mg twice daily. But if the patient is taking more than 10 mg of an ACE inhibitor, then the dose is 100 mg BD. And there should be a mandatory of 36-hour washout period for this. Means if the patient is taking an ACE inhibitor, you have to stop the ACE inhibitors. 36 hours later, you need to start the ARNI, because there is a lot of chances of angioedema and bronchospasm in these patients because of the ARB and because of the ARB component. Now, second, if the patient is on ARBs, okay, so the starting dose is based on the valsartan units if what the patient is taking on. Suppose if the ARB dose is less than or equal to 160 mg daily, then you have to start Vimada as 50 mg BD. But if the dose is more than 160, then it should be started as 100 mg BD, and there no need of having a washout period in if the patient is already on ARBs. You can start directly the ARNI. Now, what about the in-hospital patients? So in-hospital patients, the initial dose, basically it is determined by the systolic blood pressure of the patient. So if the systolic blood pressure is more than 120 mmHg, then you can start 100 mg twice daily regime. But if it is between 100 to 120 mg, then you have to start 50 mg twice daily. Okay, this is how you start for the in-hospital patients. But what is the target dose of sacubitril and valsartan which is needed? So regardless of the start dose or the clinical setting, the final dose is around 200 mg twice daily. That is the target dose of sacubitril and valsartan. And the up titration can be performed slowly every 2 weeks. So if the patient is on 50 mg, after 2 weeks, you can increase to 100, then 150, and finally, over 4 weeks, you can, over around 6 weeks, you can increase it to 200 mg. So increases in serum creatinine or potassium levels or any onset of symptomatic hypotension may either delay or prohibit the up titration. So in general, if the patient is on Vimada, increase in serum creatinine levels of less than or equal to 0.3 mg per dl or a decrease in eGFR of less than 25% from the patient baseline are considered acceptable. So you need not to stop the drug. Okay. Similarly, you can maintain a potassium level of less than or equal to 5 mg. Okay. If it is more only, you stop the drug. Otherwise, you need not to stop the drug. So this is one of the important thing while adjusting the dose or when to stop the drug. Now, what are the clinical applications of ARNI? So as we know, heart failure with reduced ejection fraction, class C, was the thing that we thought is the indication for ARNI. So there are a lot of trials which supported this. Okay, you have to just know the trial names. Okay, please go through the trials. Just if you remember the names, it is more than enough. So you have the Paradigm heart failure trial, transition trial, Pioneer HF trial, and titration trial. These trials are all for heart failure with reduced ejection fraction. Okay, now next, is there a role for heart failure with preserved ejection fraction? It does not have an official indication in these patients, but it has a beneficial effects in these patients. How? It blocks a pro-fibrotic or pro-hypertrophic metabolism, which is the function of valsartan, while stimulating an anti-fibrotic or anti-hypertrophic mechanism by the sacubitril. So, since it has some protective role, there are trials which have done or compared the role of ARNI in case of heart failure with preserved ejection fraction. So the first one is the Paramount trial, which showed that it had a greater improvements in the NYHA class, and it has a preserved better renal function compared to the valsartan group alone in patients with heart failure with preserved ejection fraction. There is one more trial, the Paragon HF trial. So it showed that ARNI was not associated with decreased CV mortality and heart failure hospitalization. So this is one of the negative trial. Okay, this is a positive trial, whereas this is a negative trial. So there is one more trial which is still ongoing, the Parallax trial. So we'll just wait for the results of this trial. So they have compared here with ACE inhibitors versus ARBs versus NORAS inhibitors, nothing but sacubitril and valsartan. So they compared these three groups and the results are still awaited. Now, the last one is, it is also used in hypertension patients. So the trial is the parameter study. So this study showed that at 3 months, the ARNI reduced central aortic systolic BP more than the olmesartan, and it also reduced the mean 24-hour ambulatory brachial as well as the central aortic systolic BP. So this is one of the new drugs for even the treatment of hypertension. What are the adverse effects of ARNI? It may lead to postural hypotension. It may lead to worsening of renal functions and hyperkalemia, may cause cough because of valsartan component and angioedema. Now coming to the contraindications, if there is a history of angioedema or anaphylaxis to ACE inhibitors or ARBs, then you should not use ARNI. If there is an underlying renal impairment, better not to use it. And if the patient has an hepatic impairment, that is the Child-Pugh-C, only if there is Child-Pugh-C, then that is a contraindication for ARNI. Now, what does the guideline suggest for ARNI? So in patients with heart failure with reduced ejection fraction, so this ARNI is included in the standard therapy, okay, both by the ESC as well as the AHA guidelines. Whereas heart failure, okay, coming to the heart failure with preserved ejection fraction, first we'll see there. So it is not included in the standard recommendation because the trials are still ongoing, okay, whereas in the AHA, it is included as a class B in the standard therapy. Okay. So now coming to the ejection fraction between midway, that is 41 to 50, ARNI can be used in the standard therapy, in the ESC guidelines, also in the AHA guidelines. Whereas those patients with improved ejection fraction, you have to continue it as in standard therapy. So basically, other than the preserved ejection fraction, you can use in the other classes of heart failure. ARNI can be used. Whereas in the preserved ejection fraction, there is no recommendation yet. Trials are still ongoing. So mostly post the trials, they might make a new recommendation. So these are my references. Thank you.